Good morning, everyone. I'm hoping everyone can hear me. We just had a little bit of technical difficulties. So I'm Robert Castro. I'm one of the infectious disease doctors at Moffitt, um, and I'm here to present vector-borne and zoonotic viral infections. Also a former fellow. It's been a while since I've been here, so I'm happy to help you guys and present to you. No conflicts of interest.
Yes,
Yeah.
there we go.
The outline for the presentation is I'm going to present both vector-borne and zoonotic viral infections. I broke it down with the vector-borne for mosquito-borne and tick-borne. The list for all these is not exhaustive, but it's just kind of the main ones. So the mosquito-borne, we have dengue, Zika, chikungunya, yellow fever, West Nile, Japanese encephalitis, which is the kind of the more common stuff we think about, and then Rift Valley fever. The tick-borne, I just wanted to mention about tick-borne encephalitis virus and Crimean Congo hemorrhagic fever virus. And the zoonotic viral infections, again, not exhaustive, but rabies virus, hantaviruses, or virus, and B virus. Just key definitions, vector-borne means it's transmitted typically by an arthropod, not exclusively, but typically mosquitoes or ticks. Zoonotic, it's transmitted from animals to humans directly or indirectly. And there's also many cases where it could be both, one or the other, depending on the situation. This graphic just shows kind of the organization of vectors. Again, we're only going to talk about viruses. Here it's kind of broken down between the type of vector. So it's not just mosquito and ticks. There's flies, lice, different organisms, and then the different diseases and the types of pathogens. So the mosquito-borne viral infections, like I mentioned before, these are the ones we're going to talk about. So first off, dengue virus, transmitted by the Aedes species, more commonly Aegypti. There's 4 serotypes, 1 through 4. Infection by one, as we learned, does not confer immunity to others. Also, when you get in, you can get issues with an adverse immune response if you get infected by one serotype and you get infected by another by antibody-dependent, exacerbation. This is the map of endemicity, tropics, subtropics, and then clinical presentation. Typically with dengue fever, the febrile phase is the first 7 days or so. Non-specific symptoms, just high fever, sometimes a rash towards the end, muscle aches, and eventually can get hemorrhagic complications if you get severe dengue. So typically you have the febrile phase in the first 7 days. Towards the end of that, then that's when you get to the critical phase, which lasts about 1 or 2 days, and you can get issues like plasma leakage or fluid retention, which can lead to shock, and also thrombocytopenia and bleeding, and also which can inevitably be fatal. The graphic down on the right just kind of shows the trend in line with the different phases. So as the fever subsides, that's when you kind of have to monitoring the person if they're going into the critical phase. If you see their hematocrit go up or their platelets start to drop, or they have any kind of signs of fluid retention, and then eventually you have the convalescence. This graphic just shows just the general dengue case management. Dengue, most of the time, like a lot of these infections, presents asymptomatically. So it's just a matter of recognizing kind of warning signs and symptoms that might suggest the person's going to get into hemorrhagic fever or any kind of severe dengue. So you start by having a presumptive diagnosis, travel history within the last 14 days, plus fever, plus kind of these non-specific symptoms, nausea, vomiting, or rash, body aches. And then you kind of assess whether they have any warning signs, which would be commonly pretty significant abdominal pain, persistent vomiting, signs of fluid retention, signs of bleeding, altered mental status, hepatomegaly, and any kind of progressive increase in hematocrit. which typically, again, you see towards the end of the febrile phase. If you have no warning signs and they have this presumptive diagnosis, then it's an outpatient management, supportive care, avoid NSAIDs, and that's about it. But if they do have any of these warning signs and or they have risk factors for severe dengue, which include issues like pregnancy, renal failure, coagulopathy, shortness of breath, not able to take PO, oral intake, they should be admitted. And then if they have signs of severe dengue from the get-go, then obviously they need to be admitted. Signs of shock, fluid retention, significant bleeding, and organ impairment. As you may be aware, dengue is important to know in Florida. We've had famous outbreaks in 2009 to 2010 in Martin County and Key West. We had not that long ago, in 2015, I believe, down in Miami. So it's something else. Most of the cases are still travel related, but there's always a possibility because of the vector being present there that it's something that have to be considered if you see these patients or it's not impossible. Next, Zika virus, again, transmitted by the Aedes mosquito. Again, mostly asymptomatic, but usually a mild illness, if anything, fever, rash, muscle aches, conjunctivitis. Famously associated with congenital Zika syndrome, more commonly microcephaly. Can be sexually transmitted as well. The map of endemicity, it's throughout, it's a little bit more expanded than dengue, but essentially it's found worldwide. Again, the kind of association with Zika is the possibility of congenital syndrome. So 5% of pregnant women that are infected can get Zika-associated birth defects. It's more commonly found in the first trimester, and the most common manifestation of that, which there are many, is microcephaly. It's in Chikyunguna virus, also spread by Aedes mosquitoes. Fever, rash, more associated with severe polyarthritis, can be associated with chronic joint pain that can last weeks to months, endemic in pretty much Africa, Asia, and the Americas. Here, this graphic just shows the symptoms. The acute symptoms are kind of the non-specific ones. Fever, 85% of people, rash, joint pain, muscle aches. They also can have conjunctivitis. And then the chronic symptoms are usually the chronic joint pain. Typically, you see in the distal extremities and more so in the lower extremities. Then yellow fever, transmitted also by Aedes species. Endemic in sub-Saharan Africa and tropical South America. And it's specific to those areas, so that's always a question you can hear. It's not in Asia. That's always try to trick you by saying that. It can cause high fevers, jaundice, bleeding, organ failure. Most cases are not severe, but 12% can progress to severe form. And if that's the case, the fatality rate's 30 to 60%. Yellow fever has a very effective live vaccine, which is important for travel medicine if you travel to these areas.
We're giving it the VA, the yellow fever vaccine.
Oh, really?
The travel clinic.
Oh, nice. Yeah, that's always in the community. It's always hard to find us if you need to get that. So this is just a graphic showing the areas of endemicity. It's the tropical South America and then sub-Saharan Africa. It's always good to check the CDC Yellow Book if you're going to travel anywhere and double check whether yellow fever vaccine is needed. So West Nile virus. This one's transmitted by the Culex mosquitoes. Birds are the main reservoir. Again, most of these infections are asymptomatic. Severe cases, it's only about 1%. Famously associated with encephalitis, meningitis, meningoencephalitis, or flaccid paralysis. More commonly, you see these severe cases in elderly and immunocompromised patients. It's important to know specifically about West Nile that it's endemic in the US and specifically in Florida. We do see it. This graphic, it's a little bit hard to see, but in the right bottom, you can see Hillsborough County. This is 2005 so far. There hasn't been any human infections, but the kind of the turquoise color indicates that there was a reported veterinary or animal infections. So it's out there in the community. I've had a case of it when I was working in Lee County. Gentleman had encephalitis. West Nile contracted it locally. So it's important to know. Japanese Encephalitis virus, transmitted by the Culex mosquitoes as well, especially in rural Asia specifically, not just Japan. There can be amplifying hosts like pigs and wading birds. Most cases are asymptomatic, but encephalitis can occur. This also has a very effective vaccine. Again, travel clinic vaccine sometimes for people that are going to travel for long durations in endemic areas, not short term. All right. Then Rift Valley fever is one that we don't tend to deal with, but it's also a vector-borne virus. It can be transmitted by both Aedes and the Culex mosquitoes. The Rift Valley is right by Kenya, and famously in Kenya, if you can tell, the reddish is kind of the areas that have reported outbreaks. Kenya is right there in the middle on the right to the right of Lake Victoria. That's where it was first described, I think, in 1931. Transmission. This one is one of these that is both zoonotic and vector-borne, so it can be transmitted through livestock, exposure to tissue of infected livestock, and also by mosquito bites. Presentation usually mild. Fevers, body aches, non-specific symptoms. You can have severe forms, which can manifest with an ocular form, eye involvement, meningoencephalitis, and hemorrhagic fever. Supportive care, vaccination of livestock, and mosquito control. What is it? One issue with, or one question prompt, a lot of times you hear with Rift Valley fever is the presence of spontaneous abortions in livestock. And that usually is a trigger for the early signs of an outbreak and how they've presented before in the past. So like we've seen questions like that. All right, next, as far as vector-borne infections, we have tick-borne viral infections. I was going to just talk about tick-borne encephalitis virus and Crimean Congo hemorrhagic fever virus. Tick-borne encephalitis virus is transmitted through tick bites by the Ixodes tick, same tick that transmit Borrelia, Lyme disease. It's not in the US, importantly. It's in Asia, in Eastern Europe, Balkans. Mostly asymptomatic, but you can get severe forms of this that cause meningitis and encephalitis. One interesting thing about the presentation is it can have a biphasic clinical course. You get better, then you get worse with the meningitis and encephalitis coming in later. There is vaccination available, which are made outside of the US. For whatever reason you find yourself in those areas in an endemic area. And Crimean Congo hemorrhagic fever, spread also by ticks or infected animal blood as well. This is kind of the area of endemicity in Africa and in Europe and the Crimea, but also it's in Mediterranean, Middle East as well. Symptoms for this usually start within the first 2 weeks of exposure. Again, non-specific symptoms if you have any. Around day 4 of the clinical disease, you can have kind of neurological manifestations like lassitude, depression, and sleepiness. Can cause severe viral hemorrhagic fever outbreaks. And if you get the severe form, it's a 10 to 40% fatality rate. There's no antiviral therapy for this. All right. Then for some zoonotic viral infections that are important, rabies, Hantavirus, Orvirus, and B virus. So rabies virus, zoonotic virus from the Rhabdoviridae family, transmitted via bites or scratches for infected animals. Worldwide, the more common association is with dogs. I think it's somewhere around like 99% of cases it's with dogs, but in the US, we don't have canine rabies. It's more, I'll show later what we typically do but dogs is worldwide the more important one. In the U.S., we get 1 to 3 cases reported per year. But regardless, we have 60,000 Americans receive post-exposure prophylaxis. So this is definitely something you'll see, have questions, be asked about, have to make recommendations about prophylaxis and all that. Very preventable with prompt post-exposure prophylaxis or vaccination. So in the U.S., this is the graphic that kind of shows in the U.S. So here you see we don't really have dog or canine rabies, but we have raccoons on the east, right there in the green. In the middle, it's mainly skunks, some foxes in the southwest and Arizona area, also in Alaska, and interestingly, in Puerto Rico, you have mongooses. So this is a graphic just showing how the infection happens. If you get bitten distally, so the dog there is biting the person in the leg, the virus replicates in the skeletal muscle, then kind of starts binding to the nicotinic acetylcholine receptors in the neuromuscular junction. Then the virus travels up the axons and the peripheral nerves towards the central nervous system, goes to the spinal cord, and then at that point infects the brain, and then sort of starts infecting centrifugally. So it goes from the middle to the outside. And so when you do get rabies, there's 2 different kinds. There's furious and paralytic rabies. Incubation period famously can be a long time, so weeks to years, but average is a few months. Here is just a little graphic that shows the different how to compare furious and paralytic rabies. Furious tends to be the most common one, about 2/3 of cases. Regardless of either one, if you start manifesting signs of rabies, usually mortality occurs within a week or 2. This is the post-exposure prophylaxis recommendations. Easy enough if you're already vaccinated. You just get 2 vaccines on day 0 and day 3. If you're not vaccinated, then we have this down here. Ideally, if you have a wound, you give human rabies immunoglobulin into the wound, and then you give the rabies vaccine, at least 4 doses. If you're immunocompromised, you'll do a 5th dose. All right. Hantaviruses, there's many different ones, so it's just sort of a group. It's transmitted via aerosolized rodent urine, feces, or saliva. Less commonly actually bites, but so it's usually aerosolized fomites. In the U.S., it's transmitted mainly by deer mouse. There's different hantaviruses worldwide. There's old world hantaviruses, which are in Europe and Asia, which typically manifest in severe forms as hemorrhagic fever or renal syndrome. In the New World, in the Americas, the severe forms tend to manifest as hantavirus pulmonary syndrome. There's no specific treatment. It's mainly supportive care. Hantavirus in the U.S. is kind of famous for its outbreak that we learn about from 93 in the 4 corners. Utah, Colorado, Arizona, New Mexico. The bottom right just kind of shows, like, at the time, how the cases jumped up in 1993 in those areas. These are all the hantavirus cases up until 2022 in the U.S. Still, everything is kind of focused in the West and the Southwest. There is a statistic out there that says that at least 94% of all cases of hantavirus in the U.S. have been west of the Mississippi River. So, okay. Then we have Orf virus. It's also zoonotic, parapox virus from sheep and goats specifically, transmitted directly from contact with infected animals or fomites, causes a self-limited pustular lesion, not an ulcer, on the hands and arms. It's a very important occupational hazard for farmers and veterinarians. So here's a goat who has Orf, and that's a finger. It's famously pustular and it's not ulcerative. Then B virus is a zoonotic virus spread by macaque monkeys. Human infection is rare, but often fatal. Transmitted mainly through bites. Importantly, less likely from scratches and other exposure to other saliva or tissues. You know, it's we learn about this because of the issue with occupational and lab exposures. Yet, you know, we hear about the different prophylaxis, specifically if it's prophylaxis, it's like Valtrex or valacyclovir and acyclovir. But if they do have any actual disease, then we do IV. So IV acyclovir or IV ganciclovir. This slide just kind of says the same thing we said before, that some viruses are both vector-borne and zoonotic. So it just depends on the context. Besides supportive care and vaccinations, which is mainly the treatments that we give or the preventative strategies, vector control in these cases is important, and as the whole strategy to kind of take care of this stuff. So insecticide treated bed nets, indoor residual spraying, larval source management, like getting rid of stagnant water to where mosquitoes will breed, personal protection, biological control, you'll hear about, and environmental sanitation and community engagement with that. All right, so in summary, vector-borne and zoonotic viruses pose significant public health threats and significant disease. Most cases are asymptomatic, but some can be fatal. Supportive care, vaccination in some cases, and vector control are all part of the prevention and treatment strategy for these organisms.